Hello, this is Dr. Sam Tsimikas, and I'm happy to present this lecture on subcellular therapeutic targeting of common lipid disorders. I'm from the University of California, San Diego, and these are my disclosures. Lipoproteins that are genetically associated with cardiovascular risk and also amenable as therapeutic targets are shown in this slide. These include ApoA of lipoprotein a, ApoC3, and angiopoietin-like 3, as well as ApoB of LDL particles. Now, this is an area that's been rapidly growing. As you can see from this slide, there's been several key lipid-targeted antisense oligonucleotide publications since 2014 in some of the top journals in cardiovascular medicine. Now, when we talk about RNA therapeutics, there are really three classes, and today we're going to focus mostly on antisense technology. But just so everyone understands the distinction, antisense is single-stranded modified DNA, and it's modified in a way that can be used as a drug. siRNA is double-stranded, so it requires two RNA molecules to be used as a therapeutic target. And there's a third therapeutic class, which is not used very commonly, which are aptamers, which we're not going to discuss today. The two mechanisms, antisense and siRNA, have slightly different mechanisms, but ultimately work in the same way in reducing protein production. Now, this is a relatively young field in its infancy. These are the only drugs approved that are in the realm of RNA therapeutics. And you see here, there are really only 4 companies so far that have successfully approved drugs, including Ionis, Sarepta, NS Pharma, and Alnylam. Now, antisense drugs target RNA via Watson-Crick base pairing, and they use a mechanism of ribonuclease H1 or RNase H1 mediated degradation as a way to prevent protein production. And as you can see here on the slide, you have DNA that gets transcribed to mRNA. The mRNA then will be translated to protein. And the mechanism of action of these drugs are quite elegant. The drugs are injected subcutaneously. They go into the target of interest or the cell of interest. They go into the nucleus, and then they bind their mRNA target in a complementary fashion. And then once this duplex is formed, RNase H1 recognizes it and cleaves the sense strand. So this strand right here that would make protein. The antisense strand can then actually go back and bind to another mRNA molecule. And for this reason, these drugs are highly long-acting. Now, when you degrade the mRNA, you actually end up having less protein. And the reason why a lot of people love this mechanism and why it's so elegant is that you never produce any protein in the circulation that you now have to remove. For example, as if you would use an antibody to bind them. Now, another advance has been the so-called GalNAc targeted antisense molecules, which increase potency 20 to 30-fold. And there's a receptor in the hepatocytes called acyl-glycoprotein. This binds a modified sugar called N-acetylgalactose. You can then bind this molecule onto your antisense molecule and inject it. And this will eventually end up into the hepatocyte, get internalized. The GalNAc is cleaved off, as you can see here. The antisense molecule then goes into the nucleus and has the effect I showed you earlier. When you do that, if you take the molecules that don't have the GalNAc and you add the GalNAc, and you now need less than 20 to 30-fold drug. So in that regard, the doses are much lower, and of course the efficacy is maintained, and therefore the therapeutic index is much better with this approach for the liver-targeted areas. I'm going to briefly mention LDL here, and inclisiran is a siRNA that targets PCSK9 mRNA. There's been several trials that have been completed. This drug is not approved yet, but it's in the regulatory pathway for being approved for lowering LDL cholesterol. And you notice here, when this drug is given, you get about a 50% reduction in LDL cholesterol. This is 2 different trials. And an advantage of this drug that it needs to be injected twice a year, which will offer convenience for lowering LDL cholesterol. Now, I'm going to take you through three other targets, LPA, ApoC3, and angiopoietin-like 3, which are novel targets, and none of these have an approved drug except ApoC3 and Waylivra in the European Union for a very rare condition called familial chylomicronemia. But I'm going to start with Lp(a) and review this and take you up to date on the trials with this target. Lp(a) is composed of an LDL-like particle to which is attached an apolipoprotein a, which is derived from plasminogen. It contains oxidized phospholipids in both the ApoA and the lipid phase of the molecule. The levels are genetically determined at birth by the number of these crinkles that are present on ApoA. Elevated levels can cause cardiovascular disease through three mechanisms: atherogenicidity through its LDL moiety, antifibrinolytic activity through its ApoA component, and pro-inflammatory effects through its content of oxidized phospholipids. The two key phenotypes are cardiovascular disease and aortic stenosis, and there are no approved pharmacological therapies at this time for it. Lp(a) was discovered in 1963 by Carrie Bird. As I mentioned, it's derived from plasminogen. There are multiple alleles of ApoA that vary according to the number of Kringle 4 type 2 repeats that you see here in yellow. And so there are over 40 different isoforms among the population that are genetically determined from each parent. In terms of its phenotypes, it causes all the cardiovascular phenotypes that are known, including aortic stenosis, but it's not associated with other non-cardiovascular phenotypes. Its metabolism is well known for the most part. Primarily, it is synthesized in the liver, and most of the plasma level is due to liver production. There are a variety of receptors that we're not going to discuss in detail that seem to clear it. The quantitative contribution of each one of those is not well defined. The plasma levels of LPA are a combination of what each chromosome essentially produces. And so you see this patient here has a small number of Kringle 4 type 2 repeats, 10. This patient has 25. Each one of these is associated with a certain plasma level. Because this has lower number of repeats, the liver can make many more particles. So when you eventually look in the circulation, the red here is the contribution of this allele, the blue is from this allele. This is 60, this is 10, so the plasma level ends up being 70 milligrams per deciliter. So unlike other proteins, this has different contributions from each allele, but ultimately it's the LPA level in the plasma, irrespective of which allele produces it, that drives the risk. It's a very prevalent risk factor. Level 60 milligrams per deciliter or higher are present about 20% of the population. So that's 64 million estimated in the US, 150 million in the EU, and 1.4 billion globally. Now, when you look at the genetic determinants of CAD, you're well familiar with most of these genes in the lipid metabolism and inflammation. This is 9p21, LDL receptor, PCSK9. Notice quantitatively, the LPA gene is the most potent risk predictor when you look at it as individual genes. There's a wide level of evidence for this being atherogenic, including primary care settings. You see here meta-analyses, Mendelian randomization, gene association studies. The risk seems to start at about 30 milligrams per deciliter, and it's approximately linear in all of these studies after that threshold. There are also data now on statins. LPA, this is a meta-analysis that we performed in over 29,000 patients, 5,751 events. Notice here that the level, again, is linear at about 30 milligrams per deciliter or higher. This is now data on PCSK9 inhibition from the Odyssey Outcomes trial. And depending which endpoint you look at, notice here, there's about a 25% higher risk of MACE within this highly well-treated population. Notice the fourth quartile is associated with the highest risk compared to the first quartile of LPA levels. And the fourth quartile here is 59 milligrams per deciliter or greater. And recall that the normal level is greater than 30 milligrams per deciliter. Now, Lp(a) is also associated with aortic stenosis, in particular through its content of oxidized phospholipids. I will not review this in this talk, but these are 7 recent studies that are contributing to the database for Lp(a) and oxidized phospholipids being a contributor to calcific aortic valve stenosis. Now, we know that these oxidized lipids and LP are present in atherosclerotic plaques. This is a saphenous vein graft intervention. And you see here the lesion before, and you see it afterwards that's treated with a stent. Notice the atheroma. This atheroma was then tested. And notice here with a mass spectroscopy, you can find very copious amounts of oxidized phospholipids in this. This is a separate patient. Notice here, this is a histology study from a patient that died. Notice the LPA, the oxidized LDL, and the oxidized phospholipids. That's very, very strongly prevalent in these large, bulky atheromas. Oxidized phospholipids predict outcomes. This is 8 studies in both primary and secondary prevention settings, and these seem to drive much of the inflammatory risk from Lp(a). This particular test is called oxidized oxidized phospholipids per ApoB, and this is now commercially available for clinical applications. Now, PCSK9 inhibition is not highly effective in patients with high LPA. This is a study called ANICH-COW. There was only a 14% reduction in patients with LPA level over 50 milligrams per deciliter. And notice there's no difference actually in the FDG uptake with PCSK9 inhibition in these high LPA patients, suggesting that one needs to reduce Lp(a) to have some effect on the vessel wall. Now, if you're seeing patients in clinic, does measuring LPA affect how you risk classify those patients? And the answer is yes. These are 2 papers published in JACC. And bottom line is in an intermediate risk category of patients, you reclassify all these patients that have different colors here, and that's approximately 40% of this group, which is about 4 out of 10 patients that you might have go into a lower risk category because their LPA levels are low, or they might go into a high risk category if their LPA levels are high. Now, Lp(a) has finally made into many guidelines. There are now 6 guidelines, and I don't expect you to read this, but this is just a summary of those guidelines. And the most recent ones that should have a major effect in LP testing are from the European Society of Cardiology and European Atherosclerosis Society, where they recommend measuring LP(a) at least once in every adult patient's lifetime to identify those with highly elevated LPA levels that might have a CVD risk equivalent to familial hypercholesterolemia. Now, along with that, an ICD-10 code is now available. So when you see a patient in clinic, you can actually diagnose them with high using these 2 codes. Okay, so let me take you through now where we are with this target. There's a phase 2 study which just completed and published. The drug was called Exia-ApoA-LRx. It's now called pelacarsen with a generic name. This is a phase 2 trial. It used 5 doses and dose regimens. Patients were treated for 6 to 12 months. The primary endpoint was LPA lowering with some additional endpoints. And here is the main findings of the study. This is placebo, and this is 20 milligrams every week, equivalent to 80 milligrams a month. Notice a mean 80% reduction in LPA levels with a nice dose-dependent reduction. Importantly, if you ask the question, what percent of patients get under 50 milligrams per deciliter, which is the recommended threshold for having minimal risk? Notice here, 98% of the patients achieve this level in this study. So that suggests that you can pretty much get everybody to go with this particular drug, and it would also be an excellent drug to use testing the LPA hypothesis. Now, in this study, there were also additional beneficial biomarker changes, including in oxidized phospholipids that you see here, LDL cholesterol, as well as ApoB100. All were significantly reduced and some substantially. These are the absolute values in the highest dose cohort. Based on this, Novartis has now started the LPA Horizons cardiovascular outcomes trial. The idea here is you take patients who are in the red, who have greater than 70 milligrams per deciliter, and they anticipate to have a median LPA of 90 milligrams per deciliter or 225 nanomoles per liter. They will be treated with pelacarsen 80 milligrams sub-Q monthly versus placebo on top of standard of care medical therapy otherwise. which can include statins, PCSK9 inhibitors, and ezetimibe. And they will be pushed into this green zone where they'll be mostly under 50 milligrams per deciliter. And the primary endpoint is going to be actually a co-primary endpoint, time to MACE in people with LPA over 70, and a second co-primary endpoint, time to MACE in people with LPA over 90. The trial is anticipated to have a median follow-up of 4.2 years, so very robust, a minimal follow-up of 2.5 years, and 993 events. So you can think, I think of this trial as, for us, that was the first statin trial. It will be robust, well-powered, in substantial duration, and it will finally test the LPA hypothesis. Okay, I'm going to switch gears now to ApoC3. ApoC3 is a small lipoprotein. It's present in all triglyceride-rich lipoproteins, but also present in LDL and HDL. It's made by the liver. It helps to both clear these large yellow particles and also smaller particles. It helps to prevent clearance of those particles because it inhibits some interaction with the receptors, but it also interferes with lipoprotein lipase activity so that it actually prevents their remodeling. Epidemiology studies have linked high ApoC3 levels to cardiovascular risk, and genetic studies have linked loss of function mutations in ApoC3 to a 40% reduction in triglycerides and a corresponding 40% reduction in cardiovascular disease. Therefore, it makes it an excellent target for both rare disorders of chylomicronemia and also common disorders of cardiovascular disease. This phase 2 trial was just reported at the European Society of Cardiology. 114 patients were randomized to these 4 doses or dose regimens along with placebo. This is the dose equivalent. They got a minimum of 6 months and a maximum of 12 months. The primary endpoint was the fasting change in triglyceride levels. And here is the final, here's the primary endpoint, placebo trending to an increase, and then the dose 50 milligrams once every 4 weeks. You see here a 60% reduction in triglycerides, which is approximately 2-fold higher than current standard of care. The secondary endpoints showed that there was a significant reduction in ApoC3 that was dose dependent, up to a 60% reduction in VLDL cholesterol, reduction in non-HDL cholesterol, reduction in ApoB in some of the cohorts, and an increase in HDL and ApoA1. Now, importantly, similar to the ApoA study, the question was asked, how many patients can get to a threshold under 150 milligrams per deciliter, which is felt to be optimal level? And notice here that 91% of patients in the highest dose achieved an triglyceride of less than 150 milligrams per deciliter. Again, speaking to the potency of this particular approach and the ability to get most patients to goal. So what are the next steps with this drug? A phase 3 study in familial chylomicronemia syndrome initiated. These patients get pancreatitis. They tend to have triglyceride levels in the thousands. There will be additional, and they have a specific genetic abnormality in the lipoprotein lipase gene family. A second indication for multifactorial chylomicronemia syndrome. These are the patients that have multiple different reasons for very high triglycerides and also have pancreatitis as their problem. Another study will be planned for patients that have triglyceride levels of 500, and eventually a cardiovascular outcomes trial in the more modest elevations of triglyceride levels. Okay, to finish up with angiopoietin-like 3, this is another lipoprotein that inhibits lipoprotein lipase activity, and therefore it's affecting both triglyceride and LDL metabolism through two pathways, one through the LPL activity, but also reduces output of VLDL. So when you look at genetic abnormalities of angiopoietin-like 3, these patients have low triglycerides lifelong, low LDL, but interestingly, they'll tend to have also low HDL cholesterol, probably because this also affects endothelial lipase. Genetic and epidemiology studies are consistent with this being an atherogenic risk factor, and therefore it's also an excellent target for therapeutic intervention. This study was just published in European Heart Journal last month. This is another phase 2 study, 105 patients, 3 cohorts. These are the monthly, weekly or monthly doses. Again, the duration of follow-up or treatment and follow-up. And this study included three difficult to treat patients that had to have both three things: high triglyceride levels, type 2 diabetes, and hepatic steatosis by MRI. So you can consider these as your most difficult patients to respond to these therapies. Notice here the baseline characteristics that are shown. Middle-aged patients, high BMIs, hemoglobin A1C controlled around 8, 17% hepatic fat fraction, and triglyceride levels 300 plus range. This is the primary endpoint, up to a 53 to 47% reduction, depending on which dose is given in the primary endpoint, which is the percent triglyceride reduction from baseline. And these are the secondary endpoints, looking at angiopoietin-like 3, total cholesterol, VLDL cholesterol, non-HDL cholesterol, ApoB, and importantly, C3 was also significantly reduced. So this drug tends to reduce most of the atherogenic lipoproteins that are present in patients. Now, this trial wasn't necessarily designed for a precursor to phase 3 because it had these very complex patients. However, Pfizer is now initiating a phase 2b study that is specifically geared to patients with cardiovascular disease and elevated triglycerides. And this is ongoing, and this will choose the dose for the phase study, which will start probably end of next year. So with that, I'd like to stop and acknowledge all of the folks that were involved in these trials at Ionis, Axia, Novartis, Pfizer, as well as academic collaborators that you see on this slide. Thank you very much.